Good evening, everybody. Welcome to this Indian Academy of Neurology Outreach Service Subsection webinar. Today we have two panelists who are going to discuss on two very important topics. Dr. Sebastian Winter, he's going to give us overview of from policy to practice, translating IGAP's recommendations into real-world neurological care. And that's going to be a great help for us because at some point of place, I suppose we are inching forward and we don't know where to move, and probably some case studies and examples and where we really stand at this point of time. To introduce Dr. Sebastian Winter, he's a consultant brain health unit, Department of Mental Health, Brain Health and Substance Use at the World Health Organization. His core interest is in public health policy, neurology and brain health, digital health and AI, and conflict prevention. Several achievements and awards to his credit. He's a permanent roster of consultants for the WHO Brain Health Unit, WHO, since 2023. BIH Junior Clinician Scientist Grant, Berlin Institute of Health. Scholar of German Academic Scholarship Foundation. BIH Research Grant, Berlin Institute of Health. MGH Graduate Student Travel Award at MGH and Harvard Medical School. German Academic Exchange Service Stipend. Capstone Program Member. Affiliate Researcher at the MGH Cancer Center at Harvard Medical School. Alumnus of the German National Academic Foundation. Dr. Sebastian, it's a proud privilege to have you with us here. Who better can overview and let us know about the IGAP, because this is one of the bases of WHO for the next 10 years from 2020. We are going to work on it till 2030, and we look forward for your talk.
Thank you so much, Dr. Bindu, and it's a pleasure to be with you here today and a privilege. So let me share my slides here and see if this works, if you can see this. I hope that you can see my screen. So once again, let me thank you, Dr. Bindu, and also the Indian Academy of Neurology Outreach Service Subsection for the privilege to be with you here today and talk about how do we get from policy to practice, specifically looking at the Global Neurology Action Plan, or IGAP as we call it, and how do we translate that into real-world neurological care. So this is, of course, a very critical topic, and we'll delve into that from a perspective of how the World Health Organization is supporting IGAP implementation on the ground. But in order to do that over the next 25 minutes or so, I'd like to first take a step back and talk about what is our global situation if we think about the global neurological burden, and then also recapitulate the mandate of this global action plan. And I know all of you or most of you will be familiar with this IGAP plan, but it makes sense to understand what the plan really sets out to do. And then we'll delve a little bit into how WHO is supporting this to then conclude with a way forward and some lessons and takeaways from my side. So again, looking at the global picture here, what I've done is I've pulled out these figures from the latest global burden of disease study. And so that study is the largest, most comprehensive effort to map the global neurological burden. And it was just published in the Lancet Neurology earlier this year. And colleagues essentially looked at 37 neurological conditions for the reference year 2021 to quantify both the morbidity and mortality in terms of disability adjusted life years. And what you see here is that relative to the previous iteration, we are seeing an expansion of the global neurological burden. We're now talking about 3.4 billion people affected by nervous system health loss at some point in 2021. And this equates to 43% of the population. So it's over 1 in 3 individuals. We're now talking 2 in 5 individuals, and we have growing threats to brain health. And this translates to almost 450 million Delhis and over 11 million deaths in 2021. And I just want to highlight here the disproportionate burden as it is affecting the global south and low and middle income countries, where we see actually 85% of the Dalits, and we have over 70% of individuals with nervous system conditions living in low and middle income countries. And so almost paradoxically, those are also the regions and countries with the highest burden are the ones that have the least resources to address them. And if you just take a look at the right-hand side in terms of workforce, and we're all aware of these stark discrepancies, we'll see a 70-fold a difference in terms of neurological health workforce in high income versus low income settings. So there still is a limited policy response, and we see that the resources are really unevenly distributed. If we zoom in a little bit on the paper, and I thought this was interesting to show, is what are these top 10 conditions that we talk about at a global level? And you'll see that here the blue bars are showing you the global top 10 with stroke having the largest burden. And on the left-hand side here, we see the situation for South Asia. So it's almost congruent with that top 10, although there are some regional differences here. And I just want to make the point, if we look at that top 10, that this GBD study really takes a life course approach. So there will be some conditions such as neonatal encephalopathy or preterm birth, which have a big burden in South Asia, that are for the first time actually included in this GBD study. And it's really showing us that if we think about neurological conditions, we need to take a life course approach, and that includes really understanding very early in life what are the conditions that are disrupting neurodevelopment and how can we find strategies to address these. The other point I would like to make is that when we talk about brain health, it's important to have this as an umbrella, but also to have it encompass peripheral nervous system conditions. And again, here, looking at the top 10, we see a diabetic neuropathy actually emerging as one of the fastest growing neurological conditions here in terms of DALIs, and this is also true for South Asia. So again, understanding that peripheral nervous system conditions should be and must be importantly included in our efforts. It makes sense to look at it from a global lens, but also to zoom in on specific conditions to understand what are the populations that are affected by neurological conditions. And while we see that males are generally more at risk, there's several conditions actually which have a higher preponderance in females, such as migraine, dementia, and multiple sclerosis, where women are disproportionately affected. So it is really important for us also to understand and to know the population who has unique needs and how to appropriately address them, also through a gender perspective. I've already spoken a bit about the treatment gap, and it is, of course, the discrepancy or the paucity of neurological workforce. And we are seeing that that is reflected also in the infrastructure available in countries. So this graph that you see on the left-hand side is taken from the WHO Neurology Atlas. So this is some years ago. We're currently in the process of updating some of that data with the Global Status Report, and I'll talk about that in a little bit. But looking at this data, and here over 100 countries were surveyed they were asked about what is the infrastructure in the country neurologically specific about neurological units, stroke units, epilepsy surgery units, and rehabilitation services. And we're seeing that it's not even 1/5 of countries here have that infrastructure available. And so what happens is that we are seeing that reflected in the diagnostic rates. So this inaccessibility of services, and I'm just giving 2 examples here for low-income settings. Only 1 in 10 people with dementia will receive a diagnosis. Only 1 in 4 people with epilepsy receive adequate treatment. So there's a huge treatment gap. And as you know, this gets compounded further by the issue of access to essential neurological medicines. Again, here, this figure is from 2017, but I think it underscores an important point. If we look at primary healthcare settings, which is for many individuals the first contact point, we're seeing that only 1 in 3 countries actually have levodopa-carbidopa formulation for Parkinson's disease, an essential medication available at primary healthcare level. And in 2017, that figure was 0% actually in the Southeast Asian region. So there's a big impetus to improve access to neurological medicines. And then finally, and this is sort of the bottom line, there is a lot of pervasive stigma and discrimination in many corners of the world. And that's not just at community level that we're seeing this in personal and interpersonal stigma, but also institutional stigma enshrined in outdated laws and legislation. And so IGAP really takes a stance towards that with specific goals, urging countries to update this outdated legislation with a view to protecting and promoting the rights of people with lived experience. So recapitulating then IGAP, and I'm sure you are aware, but I think it just makes sense to look at this and recapitulate where we are at right now. So this plan, the Global Intersectoral Action Plan, was adopted in May of 2022 in the 75th World Health Assembly. It was unanimously adopted by the 194 member states, and it sets out a really bold vision for the next 10 years, or now the next 8 years until 2031, of a world in which brain health is valued, promoted, and protected across the life course, and where neurological disorders are prevented, diagnosed, and treated, and the people affected by these conditions and their caregivers attain the highest possible level of health, which includes equal rights, opportunities, respect, and autonomy. So that umbrella goal is really multi-pronged in the sense that we're looking at reducing stigma, reducing impact and burden of neurological disorders, and improving the quality of life of people, families, and caregivers. And so it really takes a humanitarian and person-centered, a rights-based approach, and that is also reflected in these 5 strategic objectives that the plan has that we see here. I've listed them for you. You will be aware of them, but just to show that it really cuts all the way from strengthening policy prioritization and governance to providing effective, timely, responsive diagnosis, treatment, and care, implementing prevention and promotion programs, fostering research, and strengthening health information systems. And there's also an epilepsy-specific objective to strengthen the public health approach to epilepsy. Now, they're not just targets for the member states, but there are also targets in IGAP for the WHO Secretariat and for international and national partners, such as the Indian Academy of Neurology, who serve as facilitators to implementing this plan. And countries can really set also their own unique targets within that. So it's important to emphasize that IGAP has some flexibility to adapt to the national country context. I want to spend just 1-2 minutes on this integrated approach to neurological disorders, because this is something that is constantly emphasized by WHO, and it really serves as the backbone to this plan. And you see that this integrated approach, when we talk about this, it is really a multi-pronged approach. It is about integrating policies, and that means, yes, in some countries we will see standalone brain health plans, but in other countries we will also see, or we need to work towards having neurological policies embedded within existing policies. It includes policies on non-communicable disease, on mental health, on aging, on social policies, in order to be able to have them reflected and have dedicated neurological policies in the existing policy landscape. If we zoom in on a more clinical level or research level, it is about catalyzing interdisciplinary collaboration. We know that neurological conditions are complex very often, and they require multidisciplinary diagnosis, treatment, care, and research. And it is, yes, the neurologist, but not just the neurologist coordinating this care, but also actually convening a multidisciplinary platform that including neurosurgeons, pathologists, rehabilitation specialists, radiologists, palliative care specialists. So it really is about breaking down the silos that we currently see to integrate and formulate the best possible diagnosis, treatment, and care for individuals. I've already spoken to that life course approach, but I cannot overemphasize the importance of investing in the first 1,000 days of life. We know that that's absolutely pivotal for neurodevelopment, and that many conditions could be averted by investing and creating favorable conditions in those first 1,000 days of life. It requires a unique approach. And similarly, if we look at aging populations, there are unique needs, and especially looking at demographic shift, we need to do more to support aging populations in a specific manner that is tailored to their needs. At the same time, we have seen the large treatment gap, and we're dealing with very finite resources. So it is critical to align care between different neurological conditions. We know that, of course, they have differences, but there is much more commonality across the conditions in terms of referral pathways, diagnostic and treatment pathways. If we think about critical elements such as neuroimaging or CSF analysis, all of these things need to be mainstreamed in low resource settings to be able to provide care. And it also includes embedding this strategically within other programmatic areas. So, for instance, if we have a strong NCD infrastructure, we know that there are many shared risk factors with stroke and dementia and other conditions. So embedding neurological capacity, building that capacity by strategic embedding into other programmatic areas. And then finally, and I've spoken about it, this primary contact point as the primary healthcare system or community health, it is pivotal to strengthen that and to streamline neurology into that. And there are various programs such as MHGAP who are looking at building neurology capacity at primary healthcare level. Now, if we look at neurological conditions, there are often multiple and ongoing and constant care needs, and that domain also falls within the social sector. And we're seeing quite often fragmentation between the health sector and the social sector. And so it is absolutely critical to provide that continuity of care, to actually understand how is that care coordinated across sectors, not just within health, but also across sectors, which often is not the case. And the bottom line here is this holistic person-centered care, where we place the person into the center and organize the care around the person, and that is actually only possible through engagement and involvement of people with lived experience, and that includes co-creation of policies, programs, and services with these individuals to understand and to have a needs-based, evidence-informed approach and experience-informed approach to care. So with that, let me now do a little bit of a deep dive into how WHO is supporting IGAP implementation from the standpoint of the Brain Health Unit. And you see here these 5 flagship areas of how WHO is supporting this, one being leadership and advocacy, technical products, monitoring, country action, and partnerships. And I'll try and give some examples to each of these. So if we talk about leadership, yes, it is the dialogue with the ministries of health and understanding how to support at a national level. It is also about demands. And so there's a strong interest by WHO to build investment cases for neurology. And we know that actually investing in neurology care generates high returns. I'm just showing you 2 examples here again for South Asia. This is taken out of a report. It's a publication by Dan Chisholm and colleagues from the mental health unit. And they have looked at countries in the African region, but also in South Asia here, Bangladesh and Nepal. And they have calculated what is the benefit cost ratio if a standardized set of evidence-based epilepsy interventions, if a package of interventions were launched in these countries. For every dollar invested in these standardized interventions, what is the return of investment of productivity effects and social effects? So the inherent gain of being healthy. And you're seeing here that there, for every USD invested, there is up to 14 to 16 USD return. So a really high return on the investment of a standardized evidence-based set of interventions. We can do the same by looking at other conditions. So you will be aware of the Defeating Meningitis Global Roadmap, which stands alongside IGAP as a separate 10-year roadmap to defeat meningitis by 2030. And what colleagues have done is they've built an investment case to see, what if we were to implement this entire roadmap? What are our health impacts? And we'll see here that over 2.7 million meningitis cases and nearly 1 million deaths would be averted by 2030. But then looking at the socioeconomic dimension will not only save here 10 billion in terms of cost, but up to 100 billion return on investment on economic effects. And so those are actually, I think, also the numbers that are important to policymakers to understand what is the health dimension and what is the economic dimension in the long term. Because of course, there is no glory in prevention. It will take time, and that is an important factor always to remind ourselves to invest into this and to build these investment cases. Let me talk briefly about technical products. So there are several technical products that stand alongside IGAP to support countries with implementation. And some of these you will have seen before, and there are perhaps condition specific, such as those on developmental disabilities, Parkinson's disease, the epilepsy technical brief, and others are more cross-cutting, for instance, the brain health position paper. Now, there are two recent resources that were published this year, and I want to talk about these because I think they're critical when we think about IGAP implementation also in South Asia. And one is the implementation toolkit, and the other one is the Access to Medicines report. And looking at the IGAP implementation toolkit, so the idea behind that was really to target this to the decision maker, the policy maker, who is not necessarily experienced or has knowledge, specific knowledge about neurological condition, but who can put into motion the strategic actions that are necessary. And so what this toolkit does, it really explains the public health significance. It lists the core actions that underlie each of these strategic areas. And there are some case examples within the toolkit that can serve to be scaled in other countries and to inspire also policymakers as to implementing these different goals. There are also 90 tools and practical resources that are readily tailored to implementing specific actions, because we do not want to reinvent the wheel. There is a wealth of resources out there that we can readily use. So I've put the QR code here, and would encourage you to take a look at this recent resource. I also briefly want to address and talk about Access to Medicines report. So this is actually the latest technical product released, and what colleagues have done is they've done a global landscape analysis to understand why is access to medicine such a complicated issue and in many countries, and what are the cross-cutting barriers that we see. And here in this scenario, epilepsy and Parkinson's disease were used as tracer conditions, but really the takeaways apply to all neurological conditions. And first and foremost, the important point is that access is not just having medicines available, it is also affordability of medicines. So the simple formula is that access equals availability plus affordability. And that becomes evident when we look at this fishbone diagram here, which shows you in orange the more neurology specific factors that impact access, such as stigma and awareness. Are these medicines included on essential medicines lists? What are the financial aspects in terms of health financing? Is the health workforce trained to prescribe these medicines? So all of this are specific areas where we saw with epilepsy and Parkinson's disease that these are critical barriers. And at the bottom, you see some of these more systemic factors that cut through all medicines, actually, all essential medicines. So it's about more the procurement, the regional and local manufacturing, the supply chain. How do we do forecasting, procurement, distribution? What are the additional regulatory aspects we need to consider? And so all of these wheels in that machinery will ultimately feed into access. And you can appreciate the complexity of that topic, and that is reflected very much in the report. I just want to give one example here again. Looking at South Asia and India in this example, this is taken from the report, and it pulled together the availability of anti-seizure medicines. So these were different studies that used standardized WHO Health Action International methodology, which is a standardized methodology to survey anti-seizure affordability and availability. And here is an example from India where Singh et al. Conducted a study in Rajasthan and Ludhiana city, where they looked at the selection of 11 anti-seizure medicines of different formulas. Are they available in the local pharmacies? So they went to, I think, almost 50 pharmacies, and they found that availability was as low as 22%. So this remains a very prevalent and challenging issue also in India. We don't have time to go into the framework, but there is a proposed framework for action of how we can address this. And I just want you to focus on this action number 8, which is about encouraging coordination, partnership, and convening. Because at the end of the day, what is really important is that we align these different wheels in the machinery. And that goes all the way from understanding what does our manufacturing look like and how can we link that to smart forecasting to prevent stockouts of medicines. But then also, are the medicines that we really want, are they included on the essential national list of essential medicines? And are those also the ones that we have in the clinical guidelines? And are those also the ones that clinicians are able and licensed to prescribe and to the right patients? So there are many, many different factors that need to be considered. And one of the important pillars that needs to be conducted is to provide platforms for coordination, partnership, and convening so that these different stakeholders can align these different components. Otherwise, it will remain very fragmented and extremely difficult to ensure affordability and availability. I briefly want to talk about monitoring of the Global Action Plan. And this is really one of the core pillars of IGAP. And when we talk about monitoring, we talk about the Global Status Report on Neurology. And this will be a report forthcoming next year. And you can think of this as establishing a baseline for the IGAP targets. So the IGAP has these 5 strategic objectives with 10 targets. But first and foremost, we need to establish where are countries actually at on their IGAP journey. And so what is the baseline for each of these targets, which we will aggregate for a global level baseline. And, there's always that saying, what gets measured gets done. And I think that's true. So we need to actually start to understand how can we put a measurement and accountability mechanism in place. It also helps us to leverage real-world data and to tailor key priority actions for country support. So in that report, we will use that data to derive actionable evidence-informed recommendations. And prospectively, we wish to track country progress towards achieving the targets. And so this was done by disseminating a country-level survey earlier this year. There were designated focal points in each country assigned, and we're still finalizing the data collection process and anticipate launch of the report next year. The report is primarily aimed at policymakers and allied stakeholders who are involved in the public health response to neurological disorders. I cannot overemphasize the importance of country action. WHO works through its 3 levels of HQ, the 6 regions, and the countries, over 100 country offices. And I just want to give a few examples of this country work, because I think it is absolutely critical when we talk about IGAP to understand what are the circumstances on the ground. And so these country IGAP workshops and demonstration projects really serve to bring all stakeholders to one table. They happen in close collaboration with ministries, with civil society, including medical organizations, patient representatives, people with lived experience, researchers and advocates who come together to understand how can they adapt IGAP to their national context, what are their most urgent priorities, what are existing resources, and who does what. And also they build consensus and align on the next immediate steps. So it is also an accountability mechanism to gain consensus. And so here you see some examples in the past years. For instance, in Ghana, a workshop was held and consensus was gained to include Parkinson medication on the essential national medicine list. In Tanzania, a similar workshop was held, and epilepsy and Parkinson medication was included in the National Health Insurance Fund, making them more affordable. So we're seeing already progress through that capacity building at the country level. And we'll have a workshop forthcoming in Europe, in Eastern Europe, in the Republic of Moldova, working with the National Neurology Society there in Moldova, working with civil society to understand what are the pressing gaps and what actions do we have for the country in the setting of IGAP. And then there's also the broader level at WHO, the WHO Special Initiative for Mental Health that you may be aware of, which was launched in 2019, and it has a bold aim to supply mental health care to 100 million more people. And as of 2023, actually 52 million more people have had mental health services at local level. It works across 6 regions here and supporting 9 countries. And the Brain Health Unit is working with some of these countries, specifically looking at epilepsy and access to medicines. And then finally, and this brings me to a close here on partnerships, I think arguably to me the most important pillar. And WHO is really in a convening role to bring together different stakeholders. And we do that through regular NGO meetings, through regional and national capacity building workshops, through engagement of people with lived experience in all of our activities, and through concrete programmatic areas like the Global Exchange platform in partnership with other universities and stakeholders, which was a platform, a knowledge exchange platform launched in the aftermath of COVID that has been very successful in catalyzing global brain health knowledge exchange over the past years. And it also goes the other way around. And I want to conclude with this. So civil society is doing tremendous work on IGAP and moving the needle on IGAP. And so it is also about engaging and supporting civil society in activities. And I've been very privileged to be part of some of these activities. Last year, we were in India. This was still in my capacity at the International Bureau for Epilepsy in my previous role, where we convened the first IGAP workshop in Jaipur in India. And we had, this was led by IEA and IES with fantastic contributions from other civil society organizations. We had policymaker involvement and also contributions by WHO Regional Office Zero. We have also had this in the setting of IGAP in the Americas with involvement by PAHO. And more recently, there was an IGAP presentation, civil society led by Epi Alliance, where our regional office colleagues in Europe engaged. So it is absolutely fundamental that this is a to and fro between civil society and WHO as a mutual synergistic approach to IGAP. And that really brings me to that conclusion that the IGAP for us, really, it is a blueprint, it is an enormous opportunity, but to make it a reality requires efforts by everyone. It requires, of course, the countries to ensure inclusion of disorders in policies and plans, to integrate neurological conditions across the sectors and look at human rights and update outdated legislation to eliminate multi-level stigma and discrimination. It is about NGOs, academics, and clinicians such as yourselves who work at the front lines and actually see people with neurological conditions day to day and understand the reality on the ground to support policymakers, because they need to have that knowledge to support them with implementation efforts, including awareness raising, serving as multiplicators, as advocates, generating knowledge as you're doing, and we're doing with this webinar, and sharing of good practices. And I'm sure we'll hear about some of these good practices also in the next talk by Professor Singh. And first and foremost, also including people with neurological conditions who should be at the heart of these efforts. We must not forget that, and it's absolutely critical that we get to an experience-informed and needs-based approach to IGAP. And so with that, I would just like to conclude. And yeah, thank you so much for your attention, and happy to answer any questions that you may have. Thanks so much.
Thank you. Thank you so much, Sebastian. That was wonderful. It was a very crisp overlay of overview we have had now. The integrated approach to neurological disease, which looks quite comprehensive, difficult to achieve at some point, we should say, because there's so many in the fishbone itself, we can say, if we take the integrated approach in the fishbone, there's so many bones that one doesn't know which one to tackle first. But as you rightly pointed out, that we have to pick up one, which is most important at our level. The investing and the gains are quite evident now. I suppose another probably 5 to 6 years, we would have more information on how much investment and gains have been there. The toolkit and the framework are in place. We need to implement it. Sebastian, a couple of questions. There are many of us who are working at the Rural Outreach Service. Mamta is here, Desh has joined us, Dr. Nirmal Surya, myself. We are working at the grassroots level, and there we find a lot of barriers, and the barriers continue to go on. It's very difficult to break through those barriers, we feel. However, we are optimistic that there has to be a... what, according to you, sitting at that place, you feel are the key barriers in implementing IGAP? What would you feel that they are there to implement IGAP in the real world neurological settings? And how do you feel this can be overcome? Any ideas for us?
Thank you so much, Bindu. And yeah, I also really appreciate the efforts that are going on at the grassroots level. And it's really important to have this, almost haptic feedback as you're doing this in real time and you're trying different things out. And I think that's exactly the approach that we need. And I always think about that through the implementation research lens. And we cannot overemphasize the importance of implementation research to understand what is actually working on the ground, number one. But number two, is that intervention also something that we can scale and then we can adapt to different contexts? And I always think that yes, contexts are very different, and that's important, but sometimes countries have excellent examples that could be replicated in other nations. And so I think from a WHO standpoint, what we're trying to do is, and what we need to do more of, is to catalyze that exchange, not just within regions, but also across regions, because there are so many good initiatives happening. Yet I always find that knowledge and awareness of them might not necessarily be the case. So you're asking about the main barriers. I think this lack of knowledge across all levels of society, and it ranges not just at the level of the general public, but also at the level of policymakers. We need to be able to sensitize them more about the importance, and that's why I showed you these investment cases, because of course we need to also consider many concurrent and competing demands. There are many challenges that we're encountering and continue to encounter at a global scale. And so being able to pivot and to understand, okay, what works also from a realistic perspective, and building that evidence and showing that to policymakers is absolutely fundamental. I also think more needs to be done in working on the ground to listen to the plurality of opinions of different stakeholders and to align and find consensus on on what the next steps are. Because if you do that very much upfront and involve people with lived experience, involve patient representatives, involve the medical society, organizations, researchers, policymakers, and you bring them all to one table, which is not always easy. But when that happens, I think something magical can happen, which is that all voices are heard and that individuals come together to align on priorities. And they also come together to agree and say, okay, let's look at the next 6 months, even if it's a small change, what are the low-hanging fruits? What are the first steps that we can do to put this into motion? Because I fully agree that IGAP itself, if you look at the 10 global targets, it's very ambitious, can be quite daunting, and in the day-to-day, you're confronted with many barriers. But doing this initial alignment, it is not just important for people to synergize together and to work, not duplicate efforts, but to work together. But it also catalyzes buy-in, because involving people late in the process time and again shows that it doesn't really work, and that you're running into one direction, but you haven't consulted with everyone first. And this is what I meant by the needs-based approach, because of course people with lived experience, they're experts in the way that they know what their condition feels like, they know what their needs are, they know how it affects their families, their environment. And so having that dialogue as you are having on the ground at grassroots level is absolutely fundamental and cannot be overstated. But of course, we need to think more about how can we scale that, how can we also publish that evidence for others to see and to be able to have a framework and replicate this. So building that knowledge platform, I think, to me is, personally speaking, absolutely critical. We need to do more of that. There's so many excellent resources lying all over the place, and people are unaware of them. And I see that time and again. So I think that those would be, for me, my main impetus, my main recommendation at this stage. I hope that answered your question at least a little bit.
Absolutely. I completely agree with you, Sebastian, that we need to, the educational awareness programs should not be only targeted to the general public. The people with lived experiences already are knowing how to go about it. But yes, policymakers need to, and I suppose they need to ensure that the necessary resources and the training and the infrastructure are in place to support. Otherwise, even if there is a desire to run the IGAP and the toolkit to get implemented, but then if there are no resources, the infrastructure and the training and the capacity building is not there, then I suppose then our hands are a little tied down. One more question to you. We just saw that there are a lot of technical products which are available. I just saw that your bio also shows that your interest in artificial intelligence. Do you think that technology and innovation can at some point be leveraged? Because it really looks, as you said, it's very ambitious on paper, but then technology, it's on everybody's hands. Can this be used to facilitate the adoption of IGAP's recommendation? Is it a feasible option, or there are certain hiccups to that?
Yeah, thank you so much, Bindu, for that important question. I think that's also something that's on everyone's mind with this AI trend that we are seeing. How can we leverage that for global health? And I think, yeah, the answer is difficult because it's yes and no. I mean, we're seeing all of these great tools. Some of them already have a proof of principles. Others are more abstract for the time being, but we're seeing every day almost new innovations. And I have been working a little bit in this field, looking at what is out there for neurology. I'm also part of the AI community of practice at WHO. So there's an internal AI community of practice and also an AI unit that specifically is looking at building capacity and consulting member states to tell them, okay, these are the technologies and digital tools that we have. And this is what, with your existing resources, you can implement now. And this is what maybe you can implement next. So they have this principle of now, next, never. What can you do already now with what you have? What can you do next? What is coming down the tracks? And what should you never do because it's not actionable and it is out of context? And I think that's a kind of good approach to think about that when we think about neurology, right? There are very new things coming down the track, such as using retinal fundus images to predict neurological conditions like a stroke, dementia, to measure differences in chronological and biological retinal age. That is, of course, great because it's a technology that you can scale. But at the same time, as you've said, the infrastructure and resources need to be in place, because we also, from an ethical standpoint, diagnosing everyone, but then not having any treatment options is also not feasible. So we need to think again about all of these different wheels as we think about the care continuum for neurological conditions and how strategical with the existing digital infrastructure we have or do not have can use these tools. And in many instances, as we know, there is no digital infrastructure available, or there are many gaps. This is something I think with the now, next, never concept for policymakers to think about. And again, doing these capacity building workshops is the first step to that, to really take stock and understand the reality. Yeah, that would just be my short answer to that. Thanks.
Thank you. I suppose this now, next, never is an excellent way to approach things. And I suppose as time passes, the capacity building would be in technological innovations as well. And gradually we would inch forward towards this. Thank you so much for this overview and this excellent talk, Sebastian. And I hope you stay with us for Mamta's talk as well, so that we can have your inputs as to how. Mamta is going to talk on, can outreach epilepsy clinics drive research? So Mamta is a professor at the Department of Neurology at AIIMS, New Delhi. Her area of interest is untreated epilepsy, epilepsy primary care, and improving access to epilepsy care. She has been awarded by the AAN, the Palatucci Advocacy Award in 2008, the Kenneth Veste Award in 2016, editorial board member of the journal Seizure, and chair of the IAN epilepsy subsection. Mamta is going to talk on, can outreach epilepsy clinics drive research?
Unmute yourself, ma'am. Thank you, Bindu. I will just share my slides. And how much time do I have?
Mamta, you can take 20 to 25 minutes, please.
Okay. So good evening, everyone. And thank you, Bindu, and thank you, of course, to the Indian Academy of Neurology for setting up these subsections which are doing such good work. And I will, in the next 20 minutes, just summarize what has been allotted to me as the topic for this evening, which is how can outreach epilepsy clinics drive research? So, so I'll begin by just, there are many definitions if you just look online, and this is one of them that, what is research? So research is the creation of new knowledge or the use of existing knowledge in new and creative ways so as to generate new concepts, methodologies, and understandings. So one wonders as to what is the purpose of research specifically in medicine. So of course, I don't think there's any disagreement that research should extend science. Eventually, in medicine, you expect this extended science to improve patient care. You can also have research which is more focused on improving patient care. So not to say that it wouldn't be extending science, but it would primarily be finding ways how to improve access, how to reduce gaps. And especially in a country like ours, I feel, and many similar countries, where, as we've just heard, for example, in the case of epilepsy, we heard that 1 in 4 patients get diagnosed or treated, which also may not really be the case in many states in the country where, treatment gaps of even 90% and beyond exist. So as long as our levels of care remain so dismal, I think we need to prioritize research which would have an immediate impact on improving patient care. And I especially mean when you are using, government funding for research, there doesn't seem to be any kind of oversight or any kind of supervision or audit as to what kind of impact that research has. And I think that that should be one of the kind of parameters or metrics that one does look at in terms of research, not just the papers published or impact factors of journals where they are published. So first of all, as to why, this thought of doing epilepsy outreach clinics even came to my mind. So All India Institute in New Delhi is a tertiary care center. And over the years, I thought that we were seeing far more patients who did not require the kind of care we were set up to provide. And as many as 43% of patients visiting the epilepsy clinic seem to not require the kind of care, tertiary care, that which one is, of course, it comes at a great cost to the patient who's unnecessarily making a long trip, generally cannot afford it, but travels to New Delhi. And it also limits the time that we have for patients who actually need care of the tertiary care level that we are set up to provide. So why were patients, rushing to AIIMS and not being treated wherever they were coming from? So that put me on this journey of outreach clinics for epilepsy. And most of the work that I'm going to talk about today actually was conceived in this, setting, which is the Lifeline Express. Worked for a long time on this train and doing about 10 projects every year, which took me across the length and breadth of the country. It started in 2009 in June from this place, Vidisha in Madhya Pradesh. And then over the next slightly more than a decade, this is the beginning, that's what I looked at like when I started those clinics. And this is a few years later when, we had a nice team from not just within the country, but friends coming from across, from different parts of the world who participated in these clinics. And the clinic took us to distant lands, states all over the country. Of course, most of the work, was centered, and probably rightfully so, in the states of Uttar Pradesh, Bihar, Jharkhand. These are the states that have the most need. But then we actually traveled far and wide, east, west, north, south. We went everywhere. And so in the next few minutes, I will summarize as to what kind of research emerged just because we were working on these clinics and privy to a lot of observations while we worked there. So this is how I visualize the healthcare system, the care that we provide, and the research related to it. So you have the healthcare system, and you have hospitals or clinics providing care to the patient. And I am trying to get a laser. Just give me a minute. So yeah, so and then you have, you actually, doctors would work with patients or in the community. So where should the research be happening? So the healthcare system, of course, is looking to find ways in which care can be improved in the community. But unless you have, your eyes and ears to the community, you probably would not be able to provide the kind of care that is going to succeed, that is acceptable, and that is possible. So this has to be a very good, well-knit, collaborative system. And I think outreach clinics give you this access to the community or to the patient in the community, where you are able to envisage, just not just the gaps that exist, but also ways in which they need to be filled, rather than just somebody sitting somewhere and thinking of a solution and trying to impose it upon a community, which generally doesn't work. So what do these outreach clinics provide? Of course, it's very obvious that, you do provide care and you provide education, which may be awareness for different stakeholders, and training for various kinds of professionals. But very importantly, and maybe often ignored or overlooked, is the opportunity for research. So when I started these epilepsy clinics, it wasn't just my worry, but a worry of a lot of my friends and colleagues, as to how would I just go and start treatments. So I was meeting patients most often who had never been treated, and all you could do was take a good history and figure out what they had and start them on treatment. So was it even possible, and was it based on any science? Could you do it without, for example, having an EEG or some kind of imaging? And this led to this research question. So what does one need when you start treatment for epilepsy? Of course, diagnosing epilepsy is a very clinical question. No matter how well resourced you are, yet, 2 or more unprovoked seizures. Now, this is a clinical paradigm. So this is a clinical judgment that you make. Does this patient have epilepsy or not? But beyond that, is it focal or is it generalized? You generally may, resort to investigations. You look at the EEG to see if there are generalized discharges. You might look at imaging to look at to search focal lesions. So what if you did not have all this? Could you still categorize patients into focal and generalized epilepsy? Because we know that this has a bearing on the drug that you choose. So, we did this study in about 500 patients at the All India Institute. We looked at there were 2 investigators looking at 500 patients, one using just the history and trying to categorize patients into focal and generalized, and the other looking at the patient, taking the history, but also additionally using data from the EEG and imaging. And we found, that there were just 3% disagreements on this large 500 patient cohort, which gave us a lot of confidence that if you trained yourself and you kind of knew what to ask and were careful to kind of tease out the history properly, spend time, you were very likely to make a correct clinical categorization of the patient into focal or generalized epilepsy based just on your clinical data, without having to need the investigations. So this was the first piece of research that actually was kind of started because of what we were facing on the Lifeline Clinic. After that, there was this question that once patients are getting diagnosed and started on treatment in the Lifeline Clinic, there was a lot of skepticism. What do? You're just diagnosing and starting them on treatment and walking away, because the Lifeline Express wasn't going back to the same place. It was going to a new place every time. So there wasn't any systematic system to follow them up. So there were these questions, not just in our minds, but people around us. What was happening to these patients once they were diagnosed and then left almost without any care? So we did, we went back and we tried to follow up on these patients. One was within about 9 months of them having been started on treatment. So this looked at adherence after a single visit in about, this is about 103 patients, of which about 70% had continued taking medicine. So this was about 9 months after they had been started on treatment. So which was very reassuring that, the majority continued treatment, even if they did not have a regular follow-up facility, because they were benefiting from the treatment. But then there was the question as to, okay, they continue taking treatment within the 9 months, but what happens later on, as years go by? So then several years later, we revisited patients to see what happened at the end of 5 years. And here we were able to follow up about 490 patients. And of those, again, about 70% had continued to take treatment and were benefiting from it. Some had, of course, had their epilepsy resolved by then. And this again was compared with similar patients seen at the same timeline at the All India Institute. And I was very happy with how patients on the Lifeline, in spite of having just one consultation, were performing even in the longer term. So, but then, of course, one still continued to look at ways how we could follow up patients. And then we discovered that these small rural or small towns where we were conducting these clinics more often had nurses. They did not have doctors, but very often they had nurses. And we wanted to see if nurses could be trained to provide follow-up care. So then we conducted this study where, about 175 patients, they were followed up. They were patients of epilepsy who were following up at the All India Institute. And we in their follow-up visits, they were seen by a neurologist, and then they were also seen by a nurse who had been trained to provide follow-up care. And we discovered that not only does a trained nurse do almost as well as a neurologist, but patients somehow were happier with a nurse, because the neurologist was less likely to spend more than a few minutes with each patient, considering the large patient loads in our clinics. Whereas the nurse was, more kind of had more time to talk to the patients and ask for many other things that, the doctor was not finding time to actually do. So nurses can be used for epilepsy clinic or patient follow-up. This is what we discovered in this. And this is far before COVID struck us, when all of us, started to do telemedicine. But this was published in 2017, and it was done around 2014, 15. It took a couple of years for us to actually write it up. So here we randomized patients. About 430 patients were randomized to be followed up either in person. So they were randomized, and they were said, so usually our patients follow up at about 4 to 6 months, need-based follow-ups. So one arm was randomized to follow up in person, and the other arm was told that if you have any need, you are free to come, but otherwise we're going to give you a call. And it was just simple telephonic follow-up. It wasn't even a video call. So, and then we discovered, this generated class 1 evidence that our primary outcome was breakthrough seizures, that the two arms performed very, very, symmetrically. There wasn't really any significant difference. Not only that, patients, of course, who were followed up telephonically saved a lot of time and saved a lot of money that they had to spend if they were asked to travel. So this research question emerged, from our outreach clinic, and the results, of course, once COVID struck, then everybody was doing a lot of telemedicine. And this study, of course, since then has also been cited a lot of times, because people wrote a lot of things about how we could practice telemedicine. Now, our travels took us to places where, there are, of course, not just no neurologists, but very often even no doctor. So a dear friend of mine, Victor Patterson, and, who's a collaborator on a lot of the work that we've done in these outreach clinics, set out to actually make an app to see could we in some way engage community health workers to help with the diagnosis and management of epilepsy patients. And then this app has subsequently, of course, been validated and tested. And in this paper, we published results where the health workers were trained to use the app. It's a very simple app. It can be downloaded and used free. And the health workers were actually working in communities which, from where it took a couple of days to even walk to reach the nearest doctor. So the community health workers, whenever they would visit a family, they would use the app. And if they thought the app suggested that the person could have epilepsy, then they would get that patient, try and get that patient, motivate that patient and get them to the nearest physician. And then eventually, we did a validation, all patients who had been diagnosed with epilepsy using the app and, brought by the screening by the app and then diagnosed by the physician were again checked by a neurologist to find that it performs relatively quite safely, and about 93% agreement between the neurologist's diagnosis of epilepsy and what had been suggested by the app. So this is now, we use it in our community work in Chhattisgarh. After that, I'll tell you a little about, okay, this happened during the COVID time, actually. So we were trying to take care of all our outreach patients with telephonic follow-ups. We wanted to see what about, more extensive counseling and education. Could we do that virtually? So a digital, a brief video was used, and patients were, again, this was a randomized control trial, and there was, in one arm, we used this instructional video, and in the other arm, in addition to the video, there was a brief, say, 10-minute interactive a phone call, a video call, where the investigator actually, took questions. And so we looked at results to see, did such a interaction improve the baseline epilepsy knowledge scores of patients and caregivers? Of course, we found that just the video, even without the interactive session, just the video was enough. It raised the baseline levels in both the arms. Of course, where we had used the interactive session, that added a little, it wasn't very great, but it did make a little bit of a difference. So these patients performed better if an interactive session was also provided along with the educational material. This is a more recent publication. So when in our outreach clinics, there are times when you need a CT scan. And the question was, should you be doing, of course, all of us would, especially the ones who work in epilepsy would say, well, MRI is a gold standard for epilepsy. That's true. But does every patient require it? So, we are not talking of drug-resistant epilepsy over here. We are talking of, maybe the 60-70% of patients who are drug responsive. So whatever patient has had epilepsy, say, for 5 years or, 6 years, 10 years, that's the kind of patients you encounter very frequently in these outreach clinics. They've had focal epilepsy. Clinically, you can you think it is a focal epilepsy. Then do you do a plain CT? Do you do a contrast CT? And over the years, we had been observing that most of the focal epilepsy that we encounter is actually because of contrast, because of calcified lesions. So one wonders, why do you need to do a contrast study for that? Could the plain CT not be enough? And here in the study where we enrolled about 200 patients, and all of these patients with focal epilepsy, they underwent both a plain CT as well as a contrast enhanced CT. We discovered that, of course, most of the, more than half, about 60% patients did have a calcified lesion as the abnormality that the scan picked up, and that a non-contrast CT works as well as a plain CT. So this is a very important, I think, observation or finding in this paper, where the primary care providers do not really need to chase every patient either for an MRI or for contrast enhanced CTs. The context is important. The patient has had epilepsy for certain years. So it's not like, you start having seizures yesterday and I tell you that and I tell you that, a plain CT is enough for you. No, that it doesn't work like that. But if somebody's had epilepsy for 6 months or longer, then probably you are very safe in just doing a plain CT. So this has a lot of clinical relevance to anyone, you can read that paper further. And this again, because we were seeing every third patient, fourth patient in our outreach clinics with severe burn injuries, dental injuries, mutilated limbs. And we kind of tried to compare these injuries in patients seen in the outreach clinics with patients who were getting better care and were, although AIMS, of course, has kind of a selection bias because we offer comprehensive epilepsy care, and I have a very good and a very busy intractable epilepsy clinic and surgical program. So our patients more often are not well controlled, but yet, of course, they are on treatment. So when we compared injuries in the two cohorts, epilepsy patients at AIMS versus epilepsy patients on the Lifeline Express, the ones that we were encountering, like the first visit that we discovered that, of course, there is a significantly greater, not just burden of injury, but also of serious injuries. That it's intuitive, but it was just, to actually quantify and see how much of an impact. So you don't get a study of this kind from probably a hospital population, or not from the West at least, where people are far more often more likely to be on treatments, effective treatments, than not. And finally, this is more recently, putting all of our learning from the community regarding epilepsy and what could be done to improve the situation. We wrote this brief report where we kind of summarized as to what could be the way forward. So this understanding or insight. So all my co-authors over here have extensive outreach epilepsy work to their credit, and they have all made observations in different parts of the world. And we kind of put together our experiences and wrote this. And this also, probably, if anybody's interested, you could refer to it and you could read as to what we thought was could put us in maybe some within some distance of the IGAP ambitious targets that we've set for ourselves. And finally, based upon all this also, we got ICMR funding. This is an ongoing project in Chhattisgarh where we are looking to see, could you develop, how could you improve the systems, the processes, and make epilepsy treatments available for the 60-70% treatment responsive patients. Can treatment be made available in the community at the primary care level? And I'm really excited about our results that hopefully we'll publish soon. So this project also is totally a kind of offshoot of our understanding of epilepsy and why it remains largely untreated in many states across Central and North India even today. With that, I will end, and I have a lot of people to thank, including all my patients, mentors, family and friends, the All India Institute, of course, the American Academy of Neurology, which has been a great kind of collaboration, and the Lifeline Express and the Impact India Foundation. Thank you.
Thank you very much, Mamta. That's excellent work that you have portrayed here, and how not only the outreach programs you're doing good to the patients, but also clearly shows that the research can be driven out of it, and measurable impacts can be seen, and we can sort of implement it in various other places as well. Some couple of questions to you, Mamta, before we wind up today's webinar. What did you find was the major challenge while conducting a research there in areas?
Bindu, can you please repeat that?
So, Mamta, some couple of questions. So one is, what is the challenge? What is the biggest challenge you faced while you conducted research in epilepsy and any of those underserved areas? And how reliable and scalable did you feel was the data collection system in any of those outreach epilepsy programs? So we know that the cohort is different from what we have a cohort in a hospital area.
So the challenges to me are actually mostly of time, because the institute only permits me limited time to get off from here. Other than that, you really don't require too much. Continuity of, for example, longitudinal follow-ups. Now, in today's day and time, almost everybody has a mobile phone. So, longitudinal data collection and follow-up doesn't really remain as difficult as it was maybe a decade ago. It's much simpler now. You probably need to organize your data, and you need some kind of people, because it is an investment of a lot of time especially when you are virtually trying to take care of patients, because a lot can be missed and you don't want miscommunication to, come in the way. Other than that, I don't think, because people generally tend to be, once they meet a doctor and they benefit from treatment, contrary to what we generally think, that these people have never been treated, they are going to be very skeptical about treatment and probably are not going to be following up. Like our long-term follow-up on the Lifeline patients showed, that even without regular follow-ups, the vast majority continues treatment. So I think there are challenges, but there's nothing which is insurmountable. It's very manageable.
Thank you. So for all our outreach members and everybody, so the outreach can drive research. It could be an epidemiological study. We could look at the treatment gap in our respective areas. We could also empower them with education and awareness, and probably do a recheck as to how much they have caught up on the educational program. As mentioned by Sebastian, we could always have an anti-seizure medication access, how much is there in all the PHCs, CHCs, and in the respective small village, taluks, panchayats, and everywhere. Telemedicine integration is going to help us. Phone calls are easier. However, we should be always skeptical about the data collection system at that particular point. But then we know that we are having a huge GENS program, and most of it is also being collected by the of telephonic conversation also. Preventive measures, everything can be done. So thank you very much, Mamta, for showing us that.
I want to, before you wind up, this thing about medicines not being available, it's actually a chicken and egg thing. So if there is no doctor prescribing epilepsy medicines in a village or in a small town, how do you, or why do you expect that the pharmacist should be stocking epilepsy medicines? So, for example, very often when we visit any place and we do a quick survey of all because there are very few actually, there may be 6, 8, or 10 medicine shops, pharmacies. And once you go and you prescribe anti-seizure drugs to 200 patients in a small place, and you kind of have a liaison with the pharmacies in that area, all of them start stocking the medicine. They haven't so far because nobody was asking for it. So one drives the other. And in isolation, unless you have somebody consuming a medicine, it's probably futile to expect that the medicine or the stockist, the pharmacist should be, these are drugs which have an expiry date. Why should somebody be buying and keeping medicines that he knows nobody's going to buy? So it's a very kind of circular question, and just making a list of where all the medicines is not available probably is not looking at the entire question or problem rather.
Absolutely. So there are certain lists of essential medicines we want our PHC and a CHC to have it in stock, but obviously the private pharmacies are not going to stock it unless there is a demand for it. Thank you very much, Mamta, for that. Sebastian, would you want to add something to what we have just spoken in the second lecture here?
Yes, thanks so much also to Mamta for this very impressive talk. And I think what stood out for me most was this interesting approach that you mentioned of what we have when we look at the existing system. We have certain preconceived notions of how it works, but when you challenge it a little bit, as you've done with your implementation research, whether it's looking at whether nurses can conduct the follow-up, and you're actually seeing in many ways that they're doing a better job because they have more time. And so that to me is, I think, really where the research and the innovation happens, right? So pushing the boundaries of the existing system and being able to pivot and understand, okay, with the existing resources, what can we actually do? What do we have readily available now? It doesn't have to be some fancy AI technology. It can, help us that everyone has a mobile phone. And that we have, telemedicine, which also the pandemic helped us bring that really to our attention. So I think it's those things where we're trying to challenge constantly the status quo with implementation research and with what you're doing on the ground. And in many ways, that can lead to very surprising results. So I think that's to me, where as you were giving the talk, what stood out the most. And I think that's exactly what we need to do to identify those scalable opportunities, which might be something that we haven't even conceived in the existing system. So thank you so much for that. And thanks once again to Bindu and to the whole outreach section for the kind invitation.
Thank you very much, Sebastian. Thank you so much, Mamta, both of you. And thank you, Indian Academy of Neurology, for giving this opportunity to conduct the excellent webinar and to have these takeaway messages from here. Thank you very much.
Thank you.
Thank you.